I got several, but they're all pretty quick. You guys can see the screen?
Good.
Yep.
Start off with this one. This is a patient, and she is in her 60s, and this was a CT. This is when she presented to our institution back in 2017 with sinusitis. So show her sinuses CT. And so you can see in the paranasal sinuses, there's all this polypoid soft tissue, maxillary sinuses, ethmoid air cells. There's also bony dehiscence. We can go forward into there's involvement of the frontal sinuses and dehiscence here, the lamina fabricia, and we go posteriorly, the sphenoids are also involved. So I'll show a chest radiograph. This is, I think, later the same year, so still about 2 years ago. Pretty easy to see large nodules here. There's cavitation, and then there's some more subtle. This is just for kind of practice for looking carefully at a chest radiograph. Some more subtle stuff. Here you can see there's a abnormality here along the contour of the kind of silhouettes the paravertebral line and the descending and then the descending thoracic aorta. So something probably against the posterior mediastinum there. And another subtle thing is, and I'm not sure if the quality of imaging resolution on the images that are transmitted are good, but
Yeah, we can see it.
The azooesophageal recess, there's a little
Yep.
silhouetting right there, and then another little subtle thing right there. So a bunch of nodules, just to see them on the X-ray for practice. And here's a CT done right after the radiograph, and here these are the nodules that are easy to see in the upper lobe. Here's the nodule right against the right in the azooesophageal recess, and then nodule. So as you can expect, sinus disease and cavitating nodule. This is GPA, Wegener's previously referred to, and this is the CT I looked at a few weeks ago. So same patient. You don't see the nodules, but now you see all this consolidation. So in GPA, whenever I see diffuse consolidation, at least I'm thinking about DAH, but that's not what this was. The patient didn't have hemoptysis. So this, they did have fevers in 1 week. So this was COVID. And it's not a huge surprise somebody with a autoimmune vasculitis is going to have a bad cytokine response to coronavirus in their lungs. But
Peter, were they on any immune suppression for their GPA?
That's a good question, and I don't remember because I was preparing this case a few weeks ago. That's a good question.
Okay.
Go back and yeah. They're at some point they were, because it seems like all the nodules, the granulomas resolved.
Right.
Yeah.
Yeah. Okay, so I'll show another one here. This is another chest CT. And so here's the CT. And so you just see this patchy ground glass, some architectural distortion. It looks like it's getting worse towards the lung bases. And there's some, maybe a little bit of traction here, but it definitely seems like it's getting worse. So I had just read probably at least 4 or 5 COVID cases right before this one. So that's obviously the first thing I was worried about. But the imaging pattern kind of looks like it could be that. The fact that it's getting so much worse at the lung bases doesn't completely fit with all the other COVID cases I've seen, but the best way to tell this wasn't COVID is the patient. You look back at the 2018 scan, and you can see abnormalities there. So this was and I'll show the coronal. This patient was anti-synthetase syndrome. So just a case where you have another disease entity that could look like, it looks similar to COVID DAD. This is anti-synthetase. So fibrotic and SIP pattern.
The fibrotic. Yeah.
Okay, I will show another quick one here. So this is a coronary CTA that was read by one of our cardiology colleagues, and the patient was coming in, I think it was a middle-aged patient coming in with acute chest pain. And if you look at this RCA here, it definitely looks like it's coming from the RVOT PA right there, right? And we had multiple different phases, and in every phase it looked the exact same. So he said that this could be R-kappa, which is an extremely rare diagnosis, anomalous origin of the RCA from the PA, even much rarer than L-kappa, which is in and of itself rare. But he was astute to point out this could also be artifact. And the cath was done later, I think the next day, and it was in fact, this was actually coming from the aorta, but from the left cusp, but not from the PA. And so when I look back at this study, you can go back to the root here, and you put it on lung windows. You can see right at this key image, there's not a whole lot of motion on the scan, but right at the key image here at the aortic root, you can see misregistration and ghosting right there.
Yeah.
There's probably some at least one irregular heartbeat there, and that kind of just can throw off the whole diagnosis. So just a good example of a fake out. But this was nonetheless an anomalous coronary, just coming with the interatrial chorus, but from the left cusp, but not R-kappa. And one last one. I will show the scout radiograph, and I'm going to withhold the history, so it's not too obvious, but these are the abnormalities here, or these lines right here. So these are the paravertebral lines, and you can see they are too wide. Here's the descending aorta, and normally that should be external to the paravertebral stripes. And in this case, the paravertebral stripes are way out here. Perhaps here also there's some irregularity along the ribs and chest wall. But here's the CT. So here are the abnormalities in the paravertebral soft tissues. The bones are abnormal, markedly sclerotic everywhere. And then we have abnormal nodularity here between the ribs and the chest, and the extrapleural chest wall. And we have a huge spleen. So this is myelofibrosis. And I think you guys have, I think it was Travis, there's somebody else may have also shown this, but I remember there's a case where you guys showed diffuse ground glass in the lungs with extramedullary hematopoiesis, also in the lung parenchyma. And I don't really hear, I think this is just most likely just atelectasis down here.
Yeah, it's not severe enough to be that.
Really, yeah. Just a good example of extramedullary hematopoiesis in the setting of myelofibrosis.
Yeah. Very nice.
And that's all I have.
All right, thanks. Brian, do you have any cases?
Sure, I got two.
You'll need to turn up your volume a little bit.
Oh, sorry. Can you hear me better now?
Much better.
Yes.
Excellent. So can you guys see my screen okay?
Yeah.
Excellent. So this first one is a lady with pulmonary hypertension, and which is something I struggle with quite a bit. And they're calling her Group 1 pulmonary hypertension. This is a CT from 2016, and I think there might be some really tiny nodules here in the apices. It's tough to tell. They're kind of thicker slices, and then coming down, there's not so much nodules, perhaps as discrete nodules, as much as just maybe a little bit central lobular ground glass, but hard to tell. There was also a CTA done at that time showing lack of any significant clot burden. And this is 2020, and she's been treated for a couple years with prostaglandin therapy, and she's got pretty extensive central thickened lobular septae, and a little bit of fluid in the fissures and pleural effusions, and then just really and then sizable mediastinal and hilar lymph nodes. And I think she might still also have these really tiny nodules. I think it's harder to see with all the florid edema that she has there, but on this is her most recent radiograph. I think some of these look more nodular to me than thickened interlobular septae. So I was wondering, when you guys see something like this, at what point do you raise the suspicion of PVOD or PCH? I brought that up, and the pulmonologist thought it probably wasn't that. They thought it was probably just going to be a plexiform arteriopathy, and that maybe she was in edema at the time of that CT. Yeah, just,
Do you mind going back to the first one, Brian, the
Sure.
original one from years ago, and scroll through, make it a bit bigger and scroll through the upper lobes in particular? There's small central lobular nodules there, and then more opacity below. Certainly, if the whole lungs look like that, in a patient with pulmonary hypertension, I would think of the entity of pulmonary capillary hemangiomatosis as a potential etiology at that time, potentially.
Did they have wedge pressures, capillary wedge pressures, Brian?
Yeah. So the most recent capillary wedge pressures, which were obtained while she was on, I think, 90 or so of Remodulin, were normal. It was a mean of 10 millimeters of mercury, and she had some in the past that were slightly higher. Back in 2019, it was reported as mean of 12 in 2019. When she was on 128 nanograms back then, and then yeah.
It just looks like PAH to me. I mean, it looks like those little central lobular ground glass nodules you see in PAH. Yeah, that's my opinion.
And that she was just in
yeah, I think she's in Florida edema here. And yeah.
Cool.
So
right.
I agree. I think that these well-behaved small ground glass islands like that in the centers of the lobules are usually just plexiform arteriopathy, and PCH is more florid ground glass stuff in my experience. But how do you account for the edema currently? Is she volume overloaded? Does she have renal failure, or does she have a right to left shunt?
Or left heart dysfunction, yeah. Be curious what their echo showed.
Yeah.
Well, he said normal wedge pressures, though, right?
Yeah, the wedge pressure in the most recent study from last week was a mean of 12, I think. And then the echo from around more recently.
The other thing is she looks
70% of LVEVF.
I'm sorry. You know, she looks extremely scrawny here. This woman has no soft tissue outside of her ribs. And I just wonder if she's got a low protein and she has edema because she just doesn't have anything keeping the fluids in her intravascular space. She looks really malnourished here.
Yeah, that's a good call. She does have a low albumin.
Okay, yeah. So that could account for the edema and the soggy nodes.
Yeah, cool. All right, great. Well, thanks for going over that with me. And then this one's much more straightforward. This is a lady who had a pulmonary vein ablation. I think it was a cryoablation rather than radiofrequency. And you can see the bottom image is from 5 months ago. The top image is from more recently. And you can see that the left inferior pulmonary vein at that time back in February is just completely obliterated. It's completely thrombosed, and the left superior pulmonary vein has this really tight stenosis right here with a calcification associated with it as well. If you look at the right side of pulmonary veins, you see some calcifications associated with the right inferior pulmonary vein as well. And then interestingly also, she's got some either edema or maybe mild infarction involving the left upper and lower lobes, which has kind of waxed and waned over several exams. And her left-sided, her left lower lobe pulmonary artery has also undergone a change serially. So this was the exam from February, and you can see this filling defect involving the left lower lobe pulmonary artery. It's kind of eccentric, and then on the more recent follow-up, it's persistent and kind of shaded off to the side. So we thought this is probably just a flow phenomenon rather than a true pulmonary embolism, and probably in situ thrombosis related to decreased flow from the left-sided pulmonary venous obstruction. Well, those are my cases.
Yeah, that was a great example of the findings of pulmonary vein stenosis after that procedure. Yeah.
All right. Thank you. Okay. Who would like to show cases next?
Jeff, I have a
Okay, go ahead, Dave.
All right.
I'm going to give you a follow-up of a case that I showed a bit over a year ago of a youngish man, a guy in his 30s, who was employed cutting countertops, these synthetic materials, which often have a ton of silica in them. Things like these countertop things are called ice stone, silestone, Caesar stone, Cambria, Technic, and quartz. And quartz, for instance, is about 90% silica that's bound together in an acrylic resin. So when people cut this stuff, when they form it for your bathroom remodel or your kitchen remodel, they liberate large amounts of dust. And you know, the countertop people are often very naive about dust control and stuff like that. So there have been a number of cases of people with very accelerated silicosis from this very potent exposure to like sandblasting. So here's a guy who's roughly 37 years old, and this is his earliest radiograph. This is from 2017. It does show just this very mild abnormality, mostly in the upper lungs here. So there's something going on in these lungs at this time. And so about a year later, you can see that there has been quite a bit of progression. Now he has actually some large opacities emerging here. He's lost lung volume. The lung is becoming distorted. We're generating a juxtaphrenic peak down here because of upper lung volume loss. So this is over the course of about a year. This is 2018. And then here's his current radiograph, which just showed up and which caused me to want to show you this case again. Now he has this really dense pattern of progressive massive fibrosis. Notice the tracheal buckling here from the upper lobe volume loss, the greater juxtaphrenic peak here, which is caused by traction on the inferior accessory fissure, as we will see on CT, not traction on the inferior pulmonary ligament, which, as everyone knows, is located along the esophagus and never would think to generate a line out here. So this is rapidly progressive silicosis from this countertop fabrication. And let me show you what it looks like CT-wise here. So I would like to show you, let me show you this. Here's this early CT from 2018, and let me show you, I hope I can show these together. I hope they will come together, will or not. So here's his current CT with the dense, very dense consolidation of progressive massive fibrosis pattern. And notice when the when this occurs, it actually pulls the smaller nodules into these big conglomerate masses. And here's the inferior accessory fissure. This is inferior accessory fissure. Here's some fat on top of the diaphragm underneath the parietal pleura of the diaphragm. And this is what generates that juxtaphrenic peak. It's traction on the inferior accessory fissure, which contains the medial basal segment of the lower lobe. So this is the cause of the juxtaphrenic peak. And so this dense consolidation up here. Let me show you his earlier CT from 2018. This is 2 years before. And you can see at this point, it was primarily nodular, fine nodular disease with some beginning conglomeration, but mostly small nodules. Those small nodules have now all been sucked up into these conglomerate masses. So this is rapidly progressive silicosis from this very potent exposure from countertops.
That's terrible.
Okay.
That's got to be
So
the fastest progression.
the guy has been removed from the fabrication floor, and he's now has an administrative job. But as you can see, once the silica was deposited in the lung, even withdrawal of exposure, the lung disease is ongoing. It's very fibrogenic. I'm sorry I interrupted what you guys were saying.
Oh, David, I was just saying, I think that's the fastest accelerated silicosis I've ever seen. I mean, when they talk about it, they talk about over a 10-year period, but I mean, those changes just within the course of a year.
Yes.
Impressive.
Right.
Isn't that associated with a specific kind of, isn't the rapidly progressive one associated with a specific kind of silica?
I thought it was just very high. You usually see it like in sandblasters. I thought it was in patients with just extremely high doses of silica. But I don't know. I'll defer to David on that.
Because we've seen it at in the AFIP archives from specific coal miners, because obviously all coal has silica now, in specific regions where there's specific types of coal that they have to get through that have an increased incidence of this. So anyways.
Well, I think the thing is, Seth, the silica is the same. The coal from different parts of the country has varying amounts of silica in it.
Right.
And these days, the rich seams, the thick seams of coal, where you could be in, just mining coal all day and not have very much silica around, are pretty much gone. And so now they have these huge machines now that just grind up tremendous quantities of rock, and it's largely coal, largely silica, but the coal seams are thin and they're mixed in with it. So now the silica exposure is much greater because the thick coal seams are gone. There's a lot more silica there, and plus they have these machines that just chew up 100 times what they could do in the past. So the exposure is just overwhelming, and it's very difficult to wear any sort of dust control in the mines. It's almost unfeasible. It's hot, it's dusty, it's cramped. You can't breathe well in these things. You can't see and things like that. So the protection is just not there. So there's been an explosion of silica coming from coal mines these days that people have just started recognizing in the last 10 years or so.
Yeah.
So here's another.
Before you go on, David, just real quick, I posted in the chat an NPR article from November 2019 about this, particularly the brand Silestone. And it's saying it's up to 90% silica content.
Yeah, that's also true for quartz. This material called quartz, it's 90% silica. And we did previous remodeling in our house around the year 2000, and we put down a lot of stuff called corion. And corion, if you are shaping corion, which is another mineral dust embedded in a resin, you can get some lung disease, but that's very mild. And that material is aluminum. It's an aluminum silicate. It's not silica, so it's really not as potent. And it's also diluted. It's like 40% or something like that of the mineral. This modern stuff is highly concentrated with silica dust, and there's a little bit of resin just to bind it together. Now we're doing another remodel at this very moment, and we're very lucky that there's not a lot of construction noise in my house here. But the material we're putting in our bathroom is quartz. It's this fake stone that looks a lot like granite and stuff like that, but it's called quartz. So I have a very good contractor, and I know that all of his subs are working in shops where people are careful about what they're doing. So I hope that the person who shapes our quartz countertop for our bathroom room remodel is to taking proper precautions. So right now, the shop that generated that previous guy's thing has gone to water sprays and things like that to control the dust. So they've taken it seriously, but they're a few years too late. Okay, here's another person who has upper lung stuff that looks like a lot like progressive massive fibrosis, mid and upper lung stuff with these big blobs. Some a little bit of distortion, not like that last case. And you know, the differential diagnosis of this is sarcoidosis versus silicosis. So this is what his chest radiographs look like. This is a case that Sudhakar gave to me. And here's what the CT is. And so, I mean, this is a great case of these nice galaxy signs here. So is this, you know, classic case of sarcoidosis with some progressive massive fibrosis here, some conglomerate masses that are forming centrally and are sucking up these smaller things with time, and some calcified lymph nodes, like in that last case, and that can go with it can go with silicosis, but it's just fine for sarcoid too. Okay. So if we change windows here, let me actually change views. We notice that we have some, we have all these calcified lymph nodes, and some of them are paraesophageal. So here's, for instance, a nice node that is paraesophageal with calcification in it. Plus, there are some subpleural high attenuation things like this, and along here. Okay, so you have subpleural lesions like this. Now, Remy Jardin, Martine wrote an article about the year, I think 1990 in HAR, about these subpleural opacities in silicosis or co-workers pneumoconiosis and sarcoid, and in sometimes people who didn't have either of those, they were maybe just cigarette smokers. And she had some specimen radiographs where they'd inflated lungs and sectioned them and done micrographs, I mean radiographs of sections and things like that, and she showed quite a bit of stuff here. So the most dramatic subpleural deposits occurred in co-workers, and it's probably the silica that was mixed in with the coal there. And she talked about you know, a high attenuating masses. She really talked about, I think she was really talking about soft tissue attenuation. In other cases, she had calcification. But my experience is, if you see high attenuation, meaning calcification or mineral in these subpleural deposits, and sometimes they're frank pseudoplaques and stuff like that, that's always associated with silica rather than with sarcoid. I've never seen calcified lesions in that subpleural distribution from sarcoid, even though with sarcoid you can get calcification in the conglomerate masses. So when I see calcifications in subpleural deposits, as in this case, and when I see calcified nodes in association with the esophagus, I think that that is silicosis rather than sarcoid. So there was a big debate about whether this was sarcoid or silica, and there were biopsies, and there was refractal material in the biopsies. There were granulomas. I don't remember exactly what they biopsied, but there were granulomas, and there was, you know, polarizable material that corresponds to dust. So this is probably silicosis rather than sarcoid, despite the very nice galaxy signs up here. And for me, this finding of high attenuation subpleural stuff and calcified nodes or mineral containing nodes along the esophagus is a sign that this is probably silicosis and not sarcoid. In this case, we have biopsy proof. So, you know, Martine didn't talk about the high attenuation lesions. Now here's a current case that I saw just this week of these big central masses here and around the hilum here. This fellow is not feeling very well. Lots of distortion, again, traction, a juxtaphrenic peak down here, This is the inferior accessory fissure, not the inferior pulmonary ligament. And here's what it looks like on CT. It's abnormal, as you suspected. So we have calcified nodes in the mediastinum. We have calcifications in these conglomerate masses. And let's pull up the soft tissue window, which is going to get less distortion. We do have some subpleural stuff here. And here is high attenuation in the subpleural stuff. And sometimes these subpleural opacities extend into fissures. So sometimes I've seen little fingers coming into the lung in association with these peripheral subpleural lesions. And again, this suggests to me that this case, which is called sarcoid, is really silicosis. So we have this high attenuation stuff here, and then we have some high attenuation material in paraesophageal lymph nodes again. And so this, I think, is silicosis. So I inquired about the guy's history. He's a construction worker. So people in construction, he's been in construction forever, are exposed to sandblasting. They're exposed to concrete pouring, where concrete dust is mobilized into the air and things like that. So the most common cause of silicosis in California, for instance, is construction work. So that's a potent way to get, in many cases, of getting exposure to silica. So this guy has the high attenuation material in these subpleural deposits. He's got the paraesophageal lymph nodes. He's got the work history of being in construction. Look at all these paraesophageal nodes down here. And I think this is another one, more of them down here. This has got to be silicosis rather than sarcoid. Okay, so I think that these, the high attenuation stuff in that subpleural location, sometimes frank pseudoplaques, that really favors silicosis over sarcoid, if you haven't heard me so far. And Martine's article really talks about the genesis of these things. So you deposit the material, the dust, in your lungs, but it gets into lymphatics, and it's the lymphatics that carry it out to these subpleural locations. I think the stuff that you cough up and swallow can be absorbed from the esophagus and then can get into paraesophageal lymph nodes. And so I think it's the lymphatic mobilization of this material that causes these locations. And as we know, there are lymphatics in the intralobular septa too, and that's why you can get these finger-like protrusions, sometimes of high attenuation material, into intralobular septa in this upper lung, from this upper lung subpleural stuff. So I think if you see high attenuation stuff, think silicosis over sarcoid. So
now, David, question for you. So I've seen sarcoid, and I'm going to go back and have to look at some other cases with the pseudoplaques.
Yes, I have seen a few cases of that too.
But you're saying when they're calcified.
What?
You're saying, but when they're calcified, that would be silicosis.
Yes, I think right. And pseudoplaque I've seen it in a couple of cases of sarcoid. It's much more frequent in silica exposure.
Right.
But I think when it's calcified, then in my experience, it's always been silica. It's always been in in a miner or somebody like that.
Interesting.
And I think the paraesophageal node business is also something to keep an eye on. I don't think anybody's written about that, but I think that makes a lot of sense in terms of swallowed material, swallowed dust, then getting into lymphatics from the esophagus and into those nodes. So Martine, it's a very good article that she wrote back in 1990, and she's said that the fact that we see this same phenomenon, not the high attenuation, but that we see these subpleural deposits with sarcoid, implies that sarcoid is something that's inhaled, the way silica is something that's inhaled. It gets into lymphatics, and it's the lymphatics that carry it out to that subpleural location. So I think I think that's very, very good reasoning. Okay, well, those are my 3 cases. Sorry to badger you guys, but
we like badgers in Wisconsin. No, that's great. I'm gonna have to go back and look at my sarcoid because it's interesting. Those nodules that you showed were very stellate, which to me is much more typical of sarcoid. And in silica, you tend to get usually a little bit rounder nodules.
You're talking about, and I don't think I've seen in silicosis, I don't think that I have seen such nice galaxies.
No, that's what I'm saying. They're kind of little spiculated things, whereas I usually see with pneumoconiosis the nice round, even though they're perilymphatic, they're rounder.
Yep.
Interesting.
Okay.
All right.
So, Jeff, when you go back over your cases, see if you see any sarcoid cases with paraesophageal calcifications.
Yeah, because I got a ton of sarcoid cases, so I'm gonna have to go back through them all.
Okay.
All right. Let's see. We've got Seth and Howard.
I have some quick ones I can
All right.
shoot through. This is a guy I came across a month ago, where just had some young guy, 30s, has some fibrotic changes. You can see subpleural both in the upper lobes and in the lower lobes. And here was his CT a few years back. And so whenever you see fibrosis in a young guy, you're not thinking one of our most typical causes of UIP or something, or even NSIP in a young guy. I think he might have been in his 20s. So I always, when I see this pattern, think of, there's some sort of prior lung injury, some form. And then went back and found this CT from towards the end of, or kind of about 4 years prior, about July 2016. And here was kind of a more, I don't know what people would call this, organizing pneumonia, some sort of abnormal kind of peripheral subpleural areas of consolidation, ground glass, some reticulation. Anyways, so looked up his history. He had a history of testicular cancer and was on bleomycin, and was put on bleomycin just like a few weeks before this CT. And we all know what bleomycin can do. And so after they, he was relatively symptomatic from this, they stopped the bleomycin. And then this is just the residual fibrosis he has from that, from that bleomycin toxicity. Relatively mild, but
yeah.
This is, I don't remember what this is. Oh, yeah. I've seen some esophageal bronchial fistulas from various causes. This was a patient who had a gastric bypass in Mexico and came up with, had some fever and some issues. And I guess it's still esophageal, but I like to say it's more gastric. But you can see there's this defect near the site of the anastomosis between her stomach and esophagus. And you can see there's this tract extending up into the right lower lobe with and she had been treated with antibiotics for a while now. She had a bad kind of consolidation, nasty looking infection. So this was a gastro-bronchial fistula, really kind of esophago-bronchial fistula, but from below the diaphragm. Most of the cases I've seen have been, I think all the cases I've seen have been arising from communication directly in the thorax, not through the hemidiaphragm into the lung. So I thought that was kind of interesting. And then this is, which patient is this? Yeah, so this is a case I came across yesterday, and this just to show some of the utility of some of the technology we have. Let me just pull this up, it'll be easier. So here's her LAD, and this thing, well, you want to call that mild, it's approaching moderate. Another stenosis here, probably moderate. But if you look after this, there's this trifurcation between a diag and a septal in the LAD. And if you look at this thing on the, I'll just quickly show it to you on the actual data, not the MPRs, because MPRs can always fool you. But at some point, this vessel just goes away. So here's the LAD, you know, not looking great, but it's fine. And then it just right here, I mean, it just goes away. So here's that septal, here's that diag, and there's no LAD here, and then it comes back. So she had chest pain and a kind of a, and I was like, I don't even know why, but I had like a younger resident on, and I'm like, oh, let's, you know, this is a Medicare patient. I don't even know why I sent it to HeartFlow, because really I didn't even think it was indicated. Oh, I did. No, reason I did is because she had actually looked up and she had an equivocal stress test. So we went ahead and got the HeartFlow, and shockingly, I mean, this is her CT-FFR. And you can see that despite the stenosis being even extraordinarily tight on their recon, which it is on the CT, that there's no significant, at least on the CT-FFR, hemodynamically significant stenosis. And then when we looked at the quote unquote equivocal stress test, there wasn't any, which was about 2 months before, there wasn't any perfusion abnormality in the LAD territory. There's something along the inferior that they thought was breast attenuation or something. So this is just a really interesting case of, you know, and I'm guessing, I'm not sure what they're going to do now, if they're going to send her to cath or not, but quite a tight, severe stenosis with a CT, you know, normal CT-FFR. We know, you know, CT-FFR isn't perfect, but would also correlate again with her normal stress test. And on that same vein, then here's another case where I'll just show the recons for the sake of time. You know, this patient had a, and again, we can debate whether what people would call this stenosis here, but you know, to me, that's going through down the barrel of it. It looked moderate. I mean, it didn't, I measured it, even though our software measuring tools are not great. I kept getting, you know, 50, 60% stenosis. And we know that we always, stenosis is measurements we classify by percentage, but that doesn't mean hemodynamic significance. We can get hemodynamic significant stenosis starting at 50%, although it's quite uncommon. But, you know, this patient did a HeartFlow on, and, you know, this stenosis was quite, even though it was the same degree, you know, this one was probably, it was less, again, moderate. She did have hemodynamic significance here, and subsequently underwent a stress test because they're not really sure what to do, because it's a single vessel, relatively, you know, it's a moderate size OM, but they weren't sure if they wanted to take her to cath, and she did have a perfusion defect in that OM territory. So with a, I guess, anatomically moderate stenosis. So just shows some of the added value for HeartFlow. Again, I don't speak for them. I don't, they do have some cases that, you know, I would love to see direct catheter FFRs in all these cases to confirm whether or not they are, but we both have coexisting stress tests which show the presence of, and then on the prior study, the absence are of perfusion abnormality on stress. So just, you know, we're pretty selective about sending stuff there, but because it's expensive. And not all insurances pay for it, and Medicare does, but Medicaid doesn't. But it can be a good tool.
So, Seth, naive question: what does FFR stand for? Fractional
Flow Reserve. So what the concept is basically, it's from cath, which is the concept saying that the pressure is basically a percentage of the pressure differential proximal and distal to a stenosis. So basically, if you have like an area here, there's a mild stenosis, and the pressure distal to the stenosis is 92% of what it was proximal to it. And you really, when you get to that, really below 0.75 and 0.8 is a gray zone, but especially when you get below 0.7, so the pressure distal to a stenosis is 70% of what it is proximal, then it's considered hemodynamically significant. So this is a computer modeling software that is done by one company, and they've done this through, they won't tell you how, they give you some complex computational analysis thing, but it works pretty well.
Wow. Okay, thank you.
Yeah. All right, those are my cases.
All right, Howard.
Okay. This is a patient that was admitted to our cancer center, and treatment was started for a condition which I'll tell you about in a moment. But she became pretty symptomatic on about day 2, I think, of the institution of therapy. So this is bedside radiography, July 3, and this is the CT showing a very extensive abnormality. Obviously, this is a very nice example of a crazy paving sign. There's diffuse abnormality in the lungs, though. Some areas of sparing, the distribution is extensive, but a bit odd. And I find it difficult in the situation when we see crazy paving to know how much of the abnormality is actually in the interlobular septa versus just in the lobule adjacent to interlobular septa. But certainly, I don't see lots of typical septal lines, particularly in regions like this, or peribronchial fluid cups, for example, of interstitial edema in this person with this extensive abnormality. So of course, there's a huge differential diagnosis for an acute respiratory illness in a certain context. And the context is really important in coming up with a reasonable explanation. So this is a person that was admitted for acute promyelocytic leukemia. And this is, I think, the second day after the institution of therapy for that condition. And certainly the imaging findings are consistent with acute lung injury edema. And knowing that context, I think one can readily make the diagnosis of what used to be called the ATRA syndrome. Now it is called the differentiation syndrome, very typical in patients who receive therapy for this disorder. So now they not only use ATRA, but they use other drugs as well as arsenic trioxide. And that's a depiction of the therapy right there that she was given. And I'll make this a little bit big, but you can see here that they begin the ATRA day 1 to 6 in divided doses. And here it indicates that the arsenic is not given at the very inception. So they certainly blame classically ATRA for this entity, but also arsenic trioxide. And then apparently, and I didn't know this, but this entity may occur sometimes in the context of other therapies for AML, which I didn't know about at all. So typically they treat the patient with steroids, they hope, because they want to continue therapy, which is effective, and see how things progress. But this turns out to be, and I don't know why it has this pattern, but it turns out to be acute differentiation syndrome. It's not entirely understood why you get the lung edema. The differentiation refers to the fact that you have rapidly maturing cells, but of course they blame other things like something happens when you get cytokines, this, that, and the next thing. So I don't think it's well understood, but it's known to be a form of acute lung injury edema or increased permeability lung edema. And usually patients do okay once they treat them with steroids. Over time, this patient did not do so okay. So this is on the 27th. And because she didn't, they stopped. They stopped the drug. She wasn't doing okay. And somewhat troublesome, she started to develop these nodules separate, superimposed on this. So there was a concern for not only the differentiation syndrome, but the possibility of complicating infection now. And I'm not sure what happened to that, but rather severe disease in this person. So differentiation syndrome. This one is something we've seen a bunch, but I'm going to show it to you because this is the first time, at least here, where I have paths to show you. So this image is really nice because it's a super nice example of dendriform ossification. So this is a MIP slab, and I'll just make that and give you a feel for the locations and the amount of abnormality. The lungs in between these look just fine. So oftentimes the patients who have this don't have any symptoms, don't have to have symptoms, and you can kind of see why. I have exams that go from 2012 to now, and over that 8-year period of time, in the interest of time, I won't show it to you, the amount of disease progressed very slightly over that period of time. So I'm not sure why back when they did a biopsy of this, I wouldn't have recommended that. But it turns out that I was able to get that to show you, and I asked my pathology colleague to label that. So she was nice enough to do that. So I'll share a couple of images. She did find some fibrosis, but described that as some fibroblastic proliferation. Not very much. You can see the arrow pointing to the bone. Here is a label showing you more of the bone, recapitulation of bone, including an intramedullary space, but no hematopoiesis in that space. Here's a nice image of the bone, as well as osteocytes that are present. There you can see the pleural surface. There's a nice image of the bone, the osteocytes. Here we have some fat, some blood vessels in the marrow part of the bone. So I think, David, in particular, you'll like this, right?
Indeed, I love this.
Because we don't get biopsies for this, and this person didn't need a biopsy, but I thought that was so pretty.
Yeah, the pathology is gorgeous. Wow.
Yeah.
I didn't realize. So they're saying there's actually, that's crazy. So there's actually, you said some marrow, some fat from the marrow is in the.
Yeah. So
that's crazy. Wow.
We had that on some cases. You actually form mature, tiny little bones, and with marrow. So we've had some cases where we didn't have fat. The path was incidental to the lung biopsy for the underlying fibrosis, but it did show marrow within these lesions. It's just amazing.
Wow, that's crazy.
Yeah, bone and some bone marrow with that hematopoiesis. I thought that's really lovely.
Yeah, David, I think I remember that this type of, the kind of ossification you see with mitral stenosis doesn't have marrow. I think
that's more sophisticated than I could address. I don't know about that.
We talked about that when we wrote that paper back in, like, was it 2006 or something? 2005. Okay. But yeah, this is not, because we showed one example in the paper where we showed the little bones and it had the marrow space in it, and that was the dendriform type.
Right.
Yeah. Very nice, huh? Oh, this one is really unusual. So I was surprised to see this. And then, of course, I'd like to know if you've either seen this or heard about this. So COVID pneumonia. So I'm going to go forward in time. This radiograph from June 24, 26. July 1, patient is sicker and is now intubated. 7-3, 2 days later. Looks like that. Forward 4 days. Looks like that. And then the surprise here is 6 days later. No, sorry, not 6 days, but here's 6 days later. Still intubated, but now on the 27th. So this is a comparison between the 13th and going from the 13th, 14 days later. Look at that. Look at these huge cystic spaces that are present in this person's lungs on the 27th. And here you go. I was really surprised to see this. Look how large and the distribution of them in that person 2 weeks later. So we have other findings, of course, we just call that organizing diffuse alveolar damage. But this is the first time I've seen cystic spaces like that. Has anyone else seen that? The lung is just disappearing in there.
I've seen that in other kinds of ARDS. And, the question is how much of that is the ventilator, puffing up some spaces in stiff lungs and stuff like that. And how much of it is lung destruction from the inflammatory process. But I think the baseline is that it's related to the bad ARDS and ventilator dependence.
Yeah, we've seen that, some bad cases. You wonder if some of it's cicatricial, just this rapid pulling on the lung versus kind of the slower stuff we see with UIP. The rapid contraction, I don't know. But yeah, I've seen some cases, definitely. But I mean, that is fast, but yeah.
Yeah, pretty dramatic. Huh? So we'll keep an eye out for cases like this, but I was kind of surprised to see that. Because he was imaged at a time when he was no longer intubated and seemed to be improving. All right, Jeff, I will show the rest of mine next week or in the future too.
All right, sounds good. I just have one quick one for this week I can show. Just kind of a fun case. All right, so that's not the one I wanted. This one here. So this was a trauma case here, and there's this foreign body that turns out to be in the esophagus. And this is a vaping cartridge. So apparently this person was vaping their THC product and got into a car crash. I presume they were high at the time. And it's unclear whether the patient swallowed it to hide it from the police or swallowed it because they were vaping at the time they crashed. But
Dude, awesome.
A new form of vaping-induced chest disease.
Thoracic injury. That's freaking hilarious. So it's just the actual card. They didn't swallow the whole vape pen. It's just the little.
I think it's small. I think it's the little insert.
Dude, that is hilarious.
That's probably the little vaporizer right here that, you know, sort of, you can imagine there's a little cylinder that connects to the thing.
So I guarantee you swallowed it because you thought the cops were going to.
That's what I'm guessing, because you'd figure you might aspirate it. Like what would, yeah.
Yeah.
But what's interesting about it is you can't smell it doesn't smell like marijuana does. And that's why the kids it's so popular with kids, because no one can tell you're vaping THC.
Yeah. Odorless.
Yep. Or whatever flavor you have. Mango is the popular one. All right, guys. Thanks.
Thanks, everybody.